Okay, we're going to get started with the second next big thing session. Could you guys load the slides? Thank you so much. I appreciate it. So as Mike mentioned yesterday, there were so many compelling submissions for our next big thing session that we're having 2 of them. So I don't have the Star Trek music to accompany me. The Academy Awards are more my speed. But Mike, thanks for giving me a tough act to follow. We heard a lot about exciting things yesterday that might be in our future. Thoughts on how to fundamentally re-engineer our research paradigm, leveraging all the information that we can now collect, including EHR, GIS, social media, to improve mental health, focusing on real problems that matter to stakeholders, and a pretty lively debate about whether Alexa will prescribe Celexa. The next panel will raise more provocative themes with regard to what 2033 might look like. You'll hear from our esteemed presenters, Dr. Kimberly Hoagwood from New York University, Dr. Erin Kelly, who's standing in for Dr. John Brecky from University of Southern California, Dr. John Cahill from Yale University, and Dr. Gail Dummett from Hopkins University. Each presenter will have exactly 10 minutes to present their findings, or the Academy Awards music will start to play. Not really. I'm not that fancy. We're very fortunate today to have time as part of this panel Q&A and discussion with Dr. Camilla Jackson. Dr. Jackson is a dear colleague and friend who I have the privilege to work alongside. She is Deputy Chief Medical Officer for Child and Adolescent Services in the City of Philadelphia. In this role, Dr. Jackson provides clinical leadership to the Community Behavioral Health and Department of Behavioral Health in addressing the behavioral health needs of children in Philadelphia. Now, Dr. Jackson trained at the very best institutions with 3 Ivy League pedigrees under her belt, and she has achieved many accolades in her career, and I could talk about that and her credentials the whole time, but I won't. Instead, I would just like to highlight her commitment and passion to ensuring that children in the public behavioral health system receive the very best care. As just one example, under her watch, she has led the transformation of children's services to include an emphasis on evidence-based practices for trauma, taking the system from having 3 trauma providers to over 23 programs, providing evidence-based care to youth in just 5 years. She's never afraid to just roll up her sleeves and do what needs to get done to advocate for the youth of Philadelphia. And her work makes a difference in the lives of our most vulnerable citizens, and I learn from her every day. Dr. Jackson will share her thoughts on what she hears from our esteemed presenters at the end of the talks from the lens of a policymaker and payer in a public behavioral health setting. So I will now pass it over to Dr. Hoagwood.
Thank you so much. It's really an honor to be here, and thank you to NIMH for organizing this. So I want to put my remarks in context by addressing the question, what are the biggest drivers of social change right now? Well, I would point to 2. Move this. I would point to 2. The first one we heard about yesterday, which is the digitalization or digital technologies, which have created different ways for us to interact with one another. They've also created a massive overabundance of data, and such that there are now opportunities for new methods to analyze the big data. It's also created the opportunity for personalized healthcare with techno healthcare that will monitor all of our functions. So personalized healthcare is possible now in ways that have not been possible before. And this has basically created or conveyed power of the self. There's self-agency in terms of managing our own health, managing our own social risks. It's also done something else, this digital domination of healthcare. It is changing our mental models of what constitutes mental health and disease. And this is happening in ways that we can't completely predict right now, but it's changing the ways we think about the relationships among biology, culture, health. Neil Postman wrote an excellent book called Technopoly a number of years ago about that. Changes what we think about, what we think with, and the nature of thought and consciousness itself. The second big driver of social change, I would suggest, is commodification. And what I mean by that is commodification of service industries, creating services as objects for trade. This has led to massive consolidation, and healthcare is just one among a whole list of service industries. The airline industry has gone from 9 to 4, and those 4 control 80% of the US market. Hospital systems and mergers, went from 105 separate hospital systems down to 46, and it's shrinking even more. So that consolidation is happening at the same time that we're seeing major health system changes in the structure, the financing, the delivery of services, but even beyond that, in what hospitals, what healthcare systems and states, and I'm including those in there, who they are responsible for and to. So it's changing the nature of the health system in that it used to be responsibility for individuals with specific diagnoses. More and more what we're seeing is social experiments that are happening in health systems and states where they are assuming responsibility for the social risks within communities and using some of the big data in order to drive decisions about it. These are massive changes. They're very important changes, and they have implications for what we're doing in mental health. There's recognition that these health conditions do not live in isolation from one another. Cardiovascular health is not a sole property of the heart any more than mental health or mental illness is a sole property of the brain. It has to do with the interaction. So in recognition, there are these social experiments, as I mentioned. There are at least 12 states right now that have launched statewide Medicaid accountable care organization programs that are identifying social risks such as poverty, homelessness, unemployment, food insecurities as critical health issues. And they are saying, what can we do in order to ameliorate those and improve the lives of the populations we're serving? Using big data to do this. So we're seeing that this is the power of the collective using big data to drive decisions, and digitalization is giving us power of the self. So how can NIMH build on its scientific investments, some of the biggest scientific investments in the past 10 years, in order to take advantage of this context in which we live? I would point to 3 scientific breakthroughs. There are many of them, but I'm going to point to 3 that I think have been especially compelling and important and paradigm shifting, frankly. The first one is neuroplasticity, understanding that, and early brain development. And these are NIMH investments. The second one is the effects of environmental exposure. And the third are some new methods that are coming out of a project called the Exposome. So neuroplasticity and early childhood development. We know that in addition to genetic drivers, there are things such as adversity, stress, poverty, as well as stimulation and nurturance on the positive side that impact early development. And this sets in motion the trajectory for the long haul. So these are critically important periods of time where the trajectories are set for life. There are sensitive periods early in development, as have been learned. The animal studies that have come out of some of this work is showing that maternal nurturance, for example, impacts gene expression, which in turn impacts neuronal growth. And these sensitive periods are true not only for neurodevelopment, but for the immune system, for the microbiome, for the metabolic system. So this is a period of great change, and it focuses our attention, I think it should focus our attention, on early development as a period to set in motion changes that can have intergenerational opportunities. We also know that things such as concentrated poverty are the most significant adverse event for children. The most significant adverse event. Poverty predicts brain volume in both the whole brain and the hippocampus. It predicts functional brain connectivity in areas known to be important for emotional regulation, and maternal support mediates that. So I'm pointing to all of these as a way of saying early development, early brain development is a critical time. We know a lot about what goes on. We know a lot about how to intervene then, and we know that it sets in motion things that we can go in one direction or the other. The third big development that is still in somewhat of its infancy, but it has major implications for, I think, health system change, is the exposome. So the exposome is the complement to the genomic sequencing, and what it is it's an attempt to sequence non-genetic factors that affect the life course. There are US centers. It's an international effort. NIH is putting a lot of support behind it. And it's developing methods and technologies, and this is really cool if you think about it, methods and technologies to collect samples, to systematically monitor a whole range, a broad spectrum of environmental exposures, dietary, microbiome, behavioral, therapeutic processes. This is a way that is going to be able to connect some of what the power of the self and self-agency at a biological level to the power of the environment. It's an amazing task. It is moving very rapidly. The methods are being developed. But for me, what it does is it's providing an opportunity to think about health analysis, environmental health analysis, in some very new ways that are connecting the biology and the environment in very new ways. So now if we just think about what's happening in the US, as I mentioned before, the massive healthcare changes are leading to many, many social experiments, dozens of these social experiments that are going on across the country to build healthier communities. It taps into the health equity issues that I know we all care about. Anti-poverty programs and policies are being built into some of these social experiments. There are at least 24 of them in communities and health systems and states going on right now. These anti-poverty policies for kids are including things such as pregnancy payments, livable wage laws, paid parental leave, earned income tax credits, housing choice voucher programs. So my question is, where is the services and implementation research agenda that can help inform some of these important developments? I don't see it happening yet. So I have some suggestions. I think that there needs to be an explicit focus on complex health systems and policy research with a specific priority on testing a variety of health system models designed to ameliorate social risks and their effects on children, families, and communities. This is something that is doable. It would hearken back to what we heard from Untitled in the last talk. It harkens back to the medical outcomes study that Ken Wells, who's in our audience, started in the 80s. It harkens to collaborative care models. There's an opportunity here, a major opportunity, to make a huge difference and maximize the public health impact of the investments that NIMH has. So I think we could be launching multi-site studies with states and with these communities that are innovating. We need to recognize that the data that are coming out of many of these community efforts and experiments are messy beyond belief. Actually, Wolpert and Rutter have a cool term for it called FUPS, which is flawed, proximate, flawed, uncertain, proximate, and sparse, FUPS data. But they've also come up with some ways of distilling and analyzing those data in ways that I think are really important. So we have to not shy away from it. The genomic sequencing has not shied away from messy data. We don't need to do that either. We need new methods. We need small experiments of novel payment approaches. Okay. We need to use our data systems better. And as I mentioned before, technological developments also change our mental models of disease. So there's an opportunity for doing studies of that. I think we could also be building in nudge units into some of the health systems. Rinad talked a bit about that. That is some really cool stuff coming out of behavioral economics, which is the new garb for social psychology. But there's some really, really interesting work that can come out of that. So my final point is this, and I want to be really clear about this. This new agenda that I'm suggesting would prioritize child and family health over other populations. This has not happened, but if we want the science to maximize the public health impact, and we want our services and implementation research to have the biggest impact, then I think we have to think about rebalancing the portfolio. This slide that you see right now shows the total NIMH budget and the percentage that has been allocated to child and family services research since 2000 up to the present. And you see the line is flat, the blue. It's 2 to 3%. So if there were ever a time when we could take advantage of the science and of the social context in order to maximize change, this is it. There are potential disadvantages to what I'm saying, but what's the price for not taking these risks? I leave it to your imagination and your conscience. Thank you.
Well, I am very excited to be in such illustrious company. Dr. Brecky sends his regrets for not being able to join all of you here today. But the topic that I'll be talking about with you all today is something that we've been working on together for, since 2012. A lot of what several speakers have brought up over the last couple of days has been about the importance of how do we really better forge those connections between research and practice. And so I'm here to talk to you about a model for how to actually develop research projects collaboratively with providers so that they have immediate real-world implications, while also taking advantage of interdisciplinary research collaborations. So briefly, we all are aware that there's a big gap between when research findings are published and when they're actually adopted out in the real world. And part of this is sprung from the tension between the fact that we need high-quality evidence-based practices in order to really make sure that we're improving the quality of health for our populations. But we also can't ignore the value of practice-based evidence for helping us to understand what the real-world picture is once we actually implement those things out there. And so the concept I'm talking about is a practice-based research network, or PBRN as I'll call it, which can really help to forge a connection at the intersection of these two important tensions between the need for scientific rigor and for answering real-world problems. So what is a PBRN? So a PBRN is when a group of providers come together not just for one research project, but for an ongoing collaboration where they generate questions and topics that are really relevant to the practice of mental health practitioners. And then they partner with researchers to make sure that they can answer those questions with a great deal of scientific rigor, from conceptualizing what the project should be, to using pilot testing, which was very novel for some of our practitioners, to actually taking those findings immediately and using them in practice without waiting for scientific review. And so, clicking at the wrong screen. So this is actually a concept that's been around for a long time. So back in the 1970s, PBRNs began here in the US within primary care. And it's actually become a major tool within primary care for generating research topics and executing research projects. And we actually attend a North American primary care PBRN conference every year because it's an excellent opportunity for us to learn from more established PBRNs about how to better execute projects. And unfortunately, what we've noticed, though, is that of the PBRNs that are registered with AHRQ, that less than 5% of them actually include mental health providers. And yet 30% of the research topics that have been covered by PBRNs in primary care have actually had mental health questions. So we should make sure that we're not left out of this important intersection of integrated care. And I believe that ours is actually the only one that involves a school of social work as well. So the PBRN is really a partnership. It's an ongoing collaboration with shared decision-making and shared ownership at each stage of the research process. And it's a really important, especially at the beginning phases, that the study topic comes from the practitioners and is not directed by the providers, by the researchers. So what does that look like? Like this. It is coming together, and at our first research meeting with our PBRN members, it was a room full of peers, of psychologists, psychiatrists, social workers, substance use counselors, all coming together to talk across agencies about what are the questions that are most burning for them to answer about how their practice is working. And so the value of this is that we make sure that all of the research topics that we're asking have immediate and real-world benefit for our partners. And it also helps to heal a wound within the research world with providers, because a lot of times our providers were saying that they're asked to be a part of a lot of different research projects. And unfortunately, researchers are not always so great about coming back and giving them the results of those projects in a timely manner. And so this causes a great deal of frustration and anger on their part, because they feel that they're waiting forever for answers that they helped to generate. And so that's not how we distribute information within our PBRN. We start first and foremost with disseminating the results to the participants, to their agencies, and then we help to make sure that it's also distributed at a local policy level through the Department of Mental Health, and then we start to work on disseminating it into more scientific realms and using that information to help generate interest and knowledge to use for our next project. So, PBRNs are not easy. They do require a great deal of time investment and a lot of commitment by our agency providers and by the academic researchers. It requires regular meetings and a highly participatory process allowing for the development of new research projects. It requires a lot of investment, both in terms of time and energy by both parties. And it's a really iterative process as we constantly negotiate how to best execute projects in a way that is rapid and usable. So briefly, we've developed 5 guiding principles for how to execute PBRN research. First, we always want to remember to have a real-world focus. We want to make sure that our findings are immediately usable. We also want to make sure that we are truly engaging our providers, that we're not setting the agenda for them, we're taking the lead from them and helping them to execute what they want to see done. It also needs to be reasonable and feasible. So this is something, a lot of the research projects that we do need to be something that are not highly labor intensive, but answer key questions. And then rapid dissemination. We've actually spent a lot of time working on how to refine our dissemination method within our agencies. At first we started with a white paper, and then we had little one-page, summaries of the findings, and now we've moved on to infographics that are embedded in emails instead of being attached, because no one will open an attachment to an email. So we've learned a lot over the last 6 years about how to really make sure that we're meeting our providers where they're at. And then lastly, we really want to make sure that we have research that is publishable and fundable in the future. So our PBRN is called the Recovery Oriented Care Collaborative, or the ROC, as we like to call it. And it really came together with the mission to improve the quality of behavioral health services for people with serious mental illnesses and to make sure that we're addressing health disparities that might impact their quality of life. We work with 4 of the largest agencies in Los Angeles County. For those of you who are familiar with the full service partnership model, which is analogous to the ACT program, our community partners provide about 50% of FSP services in Los Angeles County, so they have a big impact. And we are partnered with the USC School of Social Work. I myself am a psychologist, but I've been working with Dr. Brick in the School of Social Work, and I'm also jointly appointed at UCLA in a psychiatry department. So we really live in the world of interdisciplinary science. And we've been able to execute several projects, 2 of which have been published in 3 different articles. And we are currently executing a multi-state, multi-PBRN study looking at how the impacts of different state policies regarding the legalization of marijuana impacts how behavioral health providers talk to their clients with serious mental illness about marijuana use. And we actually met our collaborators at the North American Primary Care PBRN conference. And that we're also working on another project with researchers at NYU, looking at how to best address community integration for individuals with serious mental illness. So I'll leave you at that. We hope that all of you will consider this is one potential mechanism for improving the health of our clients. Thank you.
Hello, I'm John Cahill. I'm a psychiatrist. I'm medical director of the STEP program, a coordinated specialty care clinic and research program for first episode psychosis, founded in 2006 in New Haven, Connecticut, and it's an honor to be here. I just want to acknowledge some collaborators and our funders. So learning health networks are clearly not a new idea, but I would argue that the implementation of LHNs is more challenging with mental health services. The individualism, diversity, and complexity of the people we attempt to serve resonates for better or worse through all levels of the system. It is therefore all the more important to focus on these 4 resource domains as identified by the Institute of Medicine: science, informatics, incentives, and culture. So here's the premise. LHNs for SMI should predominantly operate as and within complex adaptive systems. Metaphors can help us here. The creation and conservation of healthy habitats in which mental health services might thrive and evolve. Food, water, shelter, and space equate to science, informatics, incentives, and culture. Existing prevalent scientific paradigms pose some risk of reductive drift, driving previously successful and beneficial interventions into extinction. And here's a sad picture of a honeybee. So this is the Knafen Framework's sense-making model. It's popular in the management literature for understanding and best operating within a system by identifying its current state. There are 5 domains: complex, complicated, simple, chaotic, and disorder. Providing our metaphor, Knafen is the Welsh word loosely translated as habitat. The model itself does not ascribe value to each state other than an imperative to determine which of the 4 other states you are in, if in disorder. However, arguably, for LHNs and SMI, it is preferable to predominantly exist in the complex domain when exploring, and shift occasionally into the complicated, for instance, when you need to scale and exploit an intervention. So applying this to healthcare in complex states, we might say there's no one right answer, but this is what tends to work in that context. Let's try it within these safe boundaries. In complicated, with expert analysis, we can know this works with the following caveats. Here's a set of procedures that might help. In simple, we definitely know how to handle this. Follow these simple steps for ensured success. And in chaotic, no point overthinking what's causing what here. Decisive action is needed now. Unfortunately, when starting with a complex intervention, there's a tendency for reductive clockwise drifts. So we start with a creative, pluralistic, flexible system which moves into the complicated domain to exploit the new intervention, which, as we scale, can drop into simple space, complacency sits in, procedures get undermined. So we were asked for a vision of the future. Unfortunately, my first thought was a dystopian one, so I wonder what that says about me. But please indulge my somewhat over-dramatized story here. So chapter 1, chaotic. Individuals early in course of an SMI have long delays to care. Emergency and voluntary care and criminal justice system involvements are very prevalent. Shocking cases of violence become falsely associated with the illness in the national media, and it becomes an issue of public attention and political importance. Chapter 2, complex. Multiple stakeholders are gathered to discuss the issue. Resources are made available. This fosters emergence of a complex care intervention which seeds several interacting LHNs. The intervention and its flexibility is subject to multiple interpretations. Exciting new health technologies are stimulated, giving rise to big data approaches, including artificial intelligence. Complicated. Experts develop treatment algorithms to standardize and disseminate the intervention. An extensive battery of scales measures fidelity to the model and clinical outcomes. LHNs grow and merge, collaborating with basic scientists to reveal novel biomarkers predicting onset and response. AI systems show promise in early detection of illness via social media monitoring. Simple. Fueled by a positive meta-analysis, the intervention is rapidly disseminated nationally, necessitating further refinement of the model and stipulation of process measures to ensure fidelity. Funding becomes contingent on performance on the monthly battery. Clinics expend more effort feeding the database than caring for patients. AIs prove more cost-effective at detection and delivering the intervention. Return to chaos. Burnt out, providers start to dissent and leave en masse. Quality of care provided and the data sent to the health information exchange deteriorates catastrophically. Clinical staff are de-skilled, few experts remain, patients feel alienated, dismissed, and distrustful of the system, so disengage. The field is undermined. Skynet goes live, and the machines take over society. You don't have to answer that question. But there is hope. The good news is humans are naturals at handling complexity, whereas it's really hard for computers. Concretely, embracing complexity means probe, monitor, and respond to the state of the system, learn to sit and work with uncertainty, frame problems rather than seeking a one-size-fits-all solution, accept a good enough starting point. Foster a culture of constructive discourse, creativity, pluralism, and safe-to-fail experimentation. We need to be judicious when integrating technology into clinical practice so we avoid creating barriers between people. These are social illnesses. So here again are the 4 resources a healthy LHN habitat need. I would argue that the most important feature here is getting buy-in from providers and forming a non-judgmental supportive community of people. So a healthy LHN habitat counters the aforementioned reductive drift and helps us to operate in complex or complicated space, so we have happy bees. We need a paradigm shift to embrace complex systems perspectives, a culture of outcomes and population-based care inclusive of and accountable to stakeholders, especially service users and also the general public. We need dynamic and collaborative approaches to health software design and development, and new models of maintenance and ownership. We need a free flow of de-identified data facilitating translational approaches with continued transparency around data practices. We need collaboration with data scientists and statisticians to develop and implement methods more suited to this paradigm. We want to brainstorm with complexity theorists and co-evolve with other fields such as management, anthropology, even ecology, and create these water cooler type conversations perhaps of the future. So the way we're looking at things at STEP, there are 3 key elements of a population-based coordinated specialty care clinic. A network of stakeholders plus the infrastructure that connects them, linked by a system, a parsimonious, evolving set of objectives and outcomes, values and concepts that provide coherence to the network, which then supports optimal pathways, flow of patients in, through, and out of care, but also knowledge through the system. So you start with your clinic, and then the first step is to reach out to your local community. Next, we reach out to regional hubs, trying to find common ground with them. Some of these hubs may already have been part of their own LHNs. We encourage the hubs to reach out and engage spoke clinics and invite in basic science colleagues. At this point, this might look like a complete LHN, but arguably this model is still vulnerable to the reductive drift. If these connections, despite being bidirectional, they often merely just represent transactions of data. If you immerse everyone in a habitat respecting pre-existing structural links, you get the incentives and the culture as well, whilst allowing new pathways for knowledge to evolve and new expertise and innovations to emerge, perhaps from unexpected places. The habitat helps each member clinic monitor their performance to be a good enough standard, freeing them up to develop individualized solutions for their unique setting and unique set of resources to later share and potentially test across the network. So this is STEP's system. It's our set of objectives. We cluster it into access to the clinic, engagement with the clinic, and then clinical outcomes. I'm not going to labor this. It's been published. And this is the overview of STEP's NIMH-funded early detection campaign. We're engaging a local population and building a network of stakeholders, and we're also studying pathways to care. Please see Stan Mathis's poster session straight after this. This is a prototype digital habitat tailored to CSC workflow and interoperable with EHRs that we've built. It supports a continuous and collaborative software development process. It collects, aggregates, analyzes, and reports common and local elective outcomes in real time across the network. It can amplify or dampen elements within the system. It acculturates users to outcomes-based practice, offers guided resources and guided person-to-person connections. It hosts a dynamic portfolio of safe-to-fail experiments, nested video conferencing, forums, SMS, and education. Could it be the water cooler of the future? We have started to engage collaborators intentionally chosen for diversity of population served and the type of CSC. If this perspective resonates with you and you're potentially interested in getting involved, please reach out. Thank you so much.
Hi, good morning, everyone. It's an honor to be here. Thanks for giving me the opportunity to share my vision for 2033, that persons with serious mental illness will achieve health equity and, similar to persons without serious mental illness, live long, healthy lives. I'm going to show you a video clip of a smoking cessation group in a community mental health program in Maryland. Now, yeah, okay. Oh, whoops, I can do this, sorry.
Yeah, I joined this group to quit smoking for my daughters and myself, and I currently am not smoking. Almost 2 months.
Almost 2 months, there you go.
What if this were offered, what if this evidence-based program was offered and easily accessible to all consumers who wanted and needed services to decrease the risk of heart disease and early mortality? This is our vision, but we know that this is not the current state of affairs. We know, many of us here know, and some are working on to help, that persons with serious mental illness, or SMI, comprise one of the most highly vulnerable groups in the United States, dying 10 to 20 years earlier and with mortality rates 2 to over 3 times higher than the overall population. Much of this premature death is due to cardiovascular disease and is potentially preventable. All cardiovascular or CVD risk behaviors, including unhealthy diet, physical inactivity, tobacco smoking, and risk factors, BMI, obesity, hypertension, diabetes, and dyslipidemia, are markedly elevated in persons with serious mental illness, with prevalence really unthinkable, 1.5 to 3 times compared to the overall population. We know this population often receives poor quality medical care for these and other conditions, not just cardiovascular related. And while these are a public health crisis, these health and mortality gaps, there's so many barriers to progress, not just the challenge of the population itself, but provider, organizational, and policy level barriers. We know that many persons with SMI receive most of their care from the public mental health sector. And while we know that there are tailored interventions to decrease CVD risk that have been shown effective in NIH and NIMH-funded clinical trials for those with SMI, such as weight loss and smoking cessation, these have not been widely adopted in community mental health settings. So what do we need to achieve our vision to meaningfully advance health and decrease mortality disparities in SMI? Well, we need several things. We need high-quality patient-centered care for CVD risk factors, hypertension, diabetes, and dyslipidemia, with appropriate communication and coordination between primary care and psychiatrists, who are often in fragmented health systems with no incentives and high barriers to coordinate. We need effective interventions to address multiple cardiovascular risk behaviors. Many people with SMI have more than one cardiovascular risk that they need to work on. smoking cigarettes, obesity. However, those that quit smoking often gain weight. For all of these risk factors, our goal is not just to get process of care measures like counseling was delivered or a medicine was started, but to actually show impact on health outcomes. This is really hard to do. Many of our studies have been done in testing integrated care models have not quite been able to show the actual health outcomes that we need for this population. We know it is really hard to do this. Health behavior change for anyone is hard, and this population often requires intensive interventions for multiple risk factors. And we need these practices implemented broadly, scaled up in community settings so they can reach the people that need them. But we also need to make sure that they don't lose their intensity when we do that. They need to be able to fit into the communities, and like Rinad mentioned earlier, many of these settings are really concerned with keeping their doors open. Their mission is behavioral health, and even though they probably many do want to help with these other issues, they are not necessarily paid for, trained, or have the bandwidth to do that. So in order to meaningfully advance health and decrease mortality disparities for this population, we need development and testing of implementation strategies for scalable, practical, effective interventions. This brings us to the ALACRITY Center, which we are actively expecting NIMH funding to begin. So let me tell you a little bit about what we're planning. Yeah. It says pending at the bottom. Our conceptual framework is based on Proctor's model of implementation research, and we'll be developing and testing implementation strategies to enhance implementation of evidence-based practices, addressing all the CVD risk factors and behaviors. We're going to be measuring the full array of implementation outcomes, using standard measures where available. We're going to be measuring process of care outcomes, and then preliminary health outcomes, which is, of course, our ultimate goal. The center is going to be anchored on 3 implementation intervention R34 style pilot studies. Together, these are going to test strategies for increased implementation of evidence-based interventions for CVD risk factors in the community mental health setting. So the first one is going to be adapting the weight loss intervention that we tested in the ACHIEVE trial to a more portable method of intervention that can be used more broadly. The second one, we're going to be focusing on smoking cessation in community mental health clinics, both using a population health model where we're helping clinics to identify smokers, and then providing evidence-based pharmacotherapy and counseling. And the third one is going to be based on trying to improve the Maryland Health Home model for better delivery of evidence-based care for hypertension, diabetes, and dyslipidemia. This is, as Jürgen said, kind of the potentially messy part, but in terms of really using real-world laboratories to test these, but we believe that this is actually going to be a strength. We have several aspects of these pilots that go across all the pilots and that will really help us learn a lot and help us to leverage our environment. Each pilot is addressing different types of implementers across different types of community mental health programs. We're incorporating organizational strategies to support implementation. We're working with multiple stakeholders to provide iterative feedback. And really importantly, we're testing training methods to enhance implementers' person-centered counseling skills, such as motivational interviewing, and we're including a virtual avatar method to do that. I think this is really one of the most important things because health behavior change is so difficult in this population, and we need to be able to help train community mental health providers to be able to do this, but not in a time-intensive way. We also are having methods projects that will synergize with the research projects and help us advanced methods in these areas for scaling up physical health intervention. We have one project that's actually focused on, specifically on the avatar-assisted training, assessment, and motivational interviewing. We're doing human factors engineering. We're going to create a toolkit to support implementation. We're also using smart trial design, and we're going to be building a system science model to help characterize the long-term health impact of these. So we are planning for the center to have a big impact, both shorter term and also hopefully longer term, improving health and reducing excess mortality. We're really looking forward to training the next generation of researchers in this area. We have a broad group of transdisciplinary researchers that were involved in the application, but we're also looking to welcome a lot of other people, including trainees from different backgrounds, and we're really looking forward to working with the community as well. So let's come back to our vision, which hopefully the ALACRITY Center and the work that others in this area are doing can reach. We envision an environment where persons with SMI receive high-quality medical and mental health care, as well as substance abuse treatment and social services, unhindered by fragmentation between behavioral health and general medical delivery systems, where the appropriate systems, incentives, and policies are in place to support this environment. Okay, can you play the...
fact that you keep moving, and it didn't matter how you moved, and things were slow and catered to somebody that doesn't do things quickly or understand quickly. I like that a lot.
I target food got an increase in because I've been there, so I'm able to do the work easier. Like I can bend over easier now. Now I'm more stamina from losing all that weight. Trying to cut down on my sugar drinks now because I figure out the amount of sugar in the drinks is bad for my diabetes.
5, 4, 3, 2, 10 more! 9, 8, 7, 6, 5, 4, 3, 2, 1.
So this was footage from the NIMH-funded ACHIEVE trial, the behavioral weight loss intervention. I hope that there will be a day soon when evidence-based programs like this are easily accessible and offered broadly to all consumers who want and need services so they can live longer, healthier lives. Thank you very much.
So good morning, everyone. Okay, I see it advancing, good. I just want to thank Rinad and the organizers for inviting me to participate today. It's been a really stimulating day and almost a half now of talks about mental health services and policy research, which really impacts policymakers in a big way. So I think kudos to all of you in the work that you do. And I've really enjoyed hearing the visions of the next big thing from our esteemed panel here. I want to start actually by just introducing you a little bit more to myself, although Rinad did a really fantastic job. Thank you so much. I wish my mom were here to hear it. And first, I want to orient you to the policy and payer lens within which I sit. I just have a few slides around that, and then I'll share some lessons from our system with you as I think about the topics, certainly, that you've heard from today. So, okay, we're going. So our vision is really, we call this our big, hairy, audacious goal, is to really be a diverse, innovative, and vibrant organization within which we sit, empowered to support wellness, recovery, and resilience for all Philadelphians. And I'll share a little bit about how we're structured to be able to do that. I do have one disclosure in that we do have a National Child Traumatic Stress Initiative funded project for the county behavioral health system, developing evidence-based treatment capacity for kids and families exposed to trauma, and Rinad mentioned that a little earlier. We've done some really fantastic work on that. So our organizational structure, sorry, it's a bit hard to read. I live in the Valley of Death, as was mentioned earlier, so lots of pieces and parts to where we sit. But really at the top is the city of Philadelphia. That's the top green bar there. And off to the right, you'll see the organizational structure for community behavioral health. Though yesterday we learned that every system, if you learned about one system, you know one system, we also think with our system it's quite unique actually across the country. And that 21 years ago, the city of Philadelphia was allowed by the state to create its own nonprofit managed care organization for behavioral health. We sit within the seat of county government for the city. So you'll see the city at the top. There's actually a commissioner of the county behavioral health system who's appointed by the mayor, and he is the chair of the board for the Medicaid carve-out structure for the city. Below the sort of burgundy bar there, you'll see the structure of our department, which is really DBH IDS, Department of Behavioral Health and Intellectual Disability Services. We have an Office of Mental Health that really provides and assures services and payment for uninsured individuals. The Office of Addiction Services, pretty self-explanatory. The dotted line to Community Behavioral Health, which is the carve-out structure, and then the Intellectual Disability Services system. For me, coming to the city about 7 years ago was really important to understand the context within which we sit, and I think Dr. Hogue would really hit upon that, and I'll mention some thoughts about that later. But really, the Pew Foundation does a state of the city each year. For me, learning about the system, it was incredibly important to be very steeped in what is the context within which we sit, what are some of the challenges, so we know we have very high rates of poverty, and that really impacts a lot of what we do and a lot of the work that you do going to practice. We know that about 28% of our population is poor, 38% of those being children in particular, so a particular set of challenges for us. I have some highlights there around other important factors for accessing care. For example, that most of our population has struggled with transportation and don't have cars. Education is another huge issue. We only have about 60% high school graduation rate in the city. So those factors, I think, are really important for the construct within which we sit and for the work that we're trying to do to achieve our big, hairy, audacious goal. We have a new mayor, which has been really nice for the city, who's very interested in safety, health, wellness, and self-sufficiency. Philadelphia is a sanctuary city, very important as well when we think about the race and ethnic milieu within which we sit, the language differences that we need to account for in terms of developing and supporting Philadelphians with behavioral health treatment services. For me, in terms of children's services, the challenges I see, particularly as we're trying to meet out this behavioral health wellness goal, really surround the interface with our other child serving systems. So we have a school district that's pretty challenged. When I came to town a few years ago, the schools closed 10% of the schools because they were $400 million in deficit. They also laid off all the counseling staff and nurses, and over the years we built back up to a place where we went from no counselors to itinerant counselors to now one counselor per school. Also building that back up with a nursing workforce as well. But these are some of the things that I didn't necessarily think about as a child psychiatrist who got an MPH and really wanted to take what I was seeing on an individual level, working with kids and families and feeling like most of the kids I was seeing were really struggling with issues that I was really ill-prepared to think about, and wanting to be a different actor within the system. Those are the things that I didn't quite necessarily think about in terms of the big system challenges with our other child serving systems. Our child welfare system as well has been transforming itself, moving to a privatized model, but also struggling within that. So important other numbers I want you guys to know about in terms of the context within which I sit is attendant to the high poverty rate in Philadelphia in terms of Medicaid. While there are 1.5 million Philadelphians, almost 660,000 of those qualify for Medicaid. So in terms of the opportunities that we have to really influence a behavioral health and wellness agenda at a city level, they are great. And we're resourced, some would say, well, for a behavioral health system. All told, the dollars are about $1.6 billion. As I've learned over the last couple of years, I think having the opportunity through the behavioral health lens is very important in terms of service development. The constant challenges we have in terms of the fact that as we think more about population health, we're interfacing with other systems that our system is not resourced to be able to address. So thinking about housing instability and the role that plays for children, families, and adults, for example, thinking about, as I mentioned earlier, the educational challenges and the challenges with the child welfare system are incredibly heady things to be thinking about as we try to achieve our goals. So we've, despite all of those challenges, you know, Philadelphia is the birthplace of our nation. We're very entrepreneurial. We, in Philadelphia, like to think of ourselves as a commonwealth within the commonwealth. And so we had a very ambitious commissioner, who I understand you heard from a few years ago, Dr. Arthur Evans, who really helped spearhead our work into thinking about what can we do with our resources? So through the Medicaid benefit, any cost savings we have, because we're a nonprofit and we do have some cost savings at the end of each year, we're able to what's called reinvest them into innovations for our system. So we've been able to use those dollars to help support a number of evidence-based practices. Rinad mentioned earlier a center that was actually developed to really aggregate the learning from those EBP implementations, and we've had wonderful academic partners in the process in the Center for Mental Health Services and Policy Research. And we've done a great job, and I think we're addressing more kids and more families with high quality trained clinicians, but I think we still end up running into barriers around the fact that our resources alone cannot address all the systemic challenges that our community faces. So some of the other things that we've done to try to support our population, and I'll go just quickly to a social determinants of health slide, is we really tried to take a population health approach and really try to, through our lens and through our policy window, achieve the triple aim as much as possible, and now the quadruple aim as we heard about earlier. We've been busy at trying to co-locate and integrate care where possible, and also are looking at collaborative care models in terms of implementation. We have a brand new innovative first episode psychosis program that's been developed in partnership with colleagues at the University of Pennsylvania, Dr. Irene Herford. And when we see that some of the outcomes from that model, we're very excited about team-based care in the future. We've also tried to evolve our payment models to think about, as much as possible, within a fee-for-service environment, move towards alternative payment models, try to account for some of the work that clinicians have to do that are not accounted for by the strict fee-for-service structure, as well as paying for performance. We continue to have significant challenges, however, and some of that was noted earlier from our speakers this morning. So we have enormous complexity in the type of work that we try to do and addressing mental health challenges for people who are the most poor. That's who we pay for the care for. They have high levels of community violence, trauma exposure, stressed families, in particular for me, child welfare, school districts, underfunded, as I mentioned earlier, and we're sitting in the seat of a pretty overwhelming opioid epidemic with last year more than 1,200 opioid deaths in the city. We also have an ever-increasing scope of challenges, it seems, brought to our system. So $1.6 billion, it sounds a lot to city government. So there are no manner of challenges that we're not called to try to address. For example, I sat in city council hearings with our commissioner last year, hearing city council members sort of crunch the numbers to say, well, you guys provide services in these schools, but there are no counselors there. Why can't you just pay for the counselors and forget about those other services that you provide? And so I think we have a lot of work to do in terms of educating our community and stakeholders about the sort of the intensity of need for behavioral health services, particularly for kids with serious emotional disturbances, although we want to get to the point where we can help with the population level as well. Of the $1.6 billion that we have, less than 3% of that is really geared towards prevention and early intervention programming, happening. And so I think that's another note from a local level that has quite a lot of latitude in terms of the different ways that we're funded from other cities, that we're still pretty constrained by the federal and state funding policies about where our dollars can go and how they can be of a resource to vulnerable populations, despite the call for more population health focus and more impacting on social determinants of health as well. So I, as I said, was really excited to hear the talks from earlier, and the parts that really resonated with me before I go through each specifically are related to thinking about how we can shorten that research to practice gap. So I'm pretty impatient, as are a lot of people who sit in local and state governments, and we have people who are taxpayers and are consumers who want more and want better. And so that takes far too much time. I know that we all agree with that, to get to the people who need them. We also, I think a lot about applied research. So I, through my policy lens and through all the training I've had and a little bit of basic science earlier in my career, I really do try to go to the literature as I'm trying to tackle big picture challenges that are coming to our city's Department of Behavioral Health. And where I often see supports and ideas are really in these very discrete, very controlled settings. And so that's been the beauty of the partnership with Penn and thinking about implementation science and implementation science research, in that we're learning how to think about the lessons that we're learning. We're learning how to help our organization as well as our provider network become more of learning organizations, and trying to incorporate what we're seeing on the ground level back into the types of interventions that we're trying to support. So I'm very uniquely aware of how lucky we are. And when I heard earlier about places where, for very rural settings that happen in Pennsylvania as well, where there is no provider and there is no practitioner, I know that we have a lot of resources to bear. But interestingly, I think when you do have more and different types of practitioners and providers, I think those silos sometimes exist even more, at least from the lens that I sit in each day. We are actually also thinking about other workforce opportunities. So Pennsylvania has been a state that's been very forward-thinking in terms of certified peer specialist workforce on the adult side of the world, however, not so much in the children's system. So over the past few years, we've been, with any new services we roll out, developing family peer specialist opportunities within those models and looking towards youth peer specialist models as well. So one of the great opportunities I think we've had is also partnering with our research communities. And we, I think in terms of opportunities for you all to think about and about the future, thinking about those opportunities in terms of thinking through high impact interventions. So when I'm sitting and thinking about what types of services we need to bring online for supporting 10,000 kids in the city, when I look to the literature, I see models and examples that have very small impact. And so that's a struggle that we are faced with, and we try to do the best we can with the research that's out there. But oftentimes we are, as some of our panelists mentioned earlier, going with what can we call as the best practices or best models or interventions from what we see, and not research that really is taking place where people live and where implementation is happening on a larger scale at a population level. The other part that for me has been interesting about this work is I became a child psychiatrist because in my work as an adult psychiatrist, I kept thinking I wish we could get to people earlier. And once I started doing my child psychiatry training and I met my first 10-year-old who'd already been hospitalized 30 times, I thought, okay, 10 is too late. How is that possible? And so I've been thinking more, and the speaker earlier mentioned this, about models looking to support, although I don't control all of the funding to be able to shift it this way, really looking at prenatal care, and some days I actually think preconception care and support for our populations, because I do think a lot of what we are challenged with addressing we're really too late. We're really far too downstream to be able to make huge impacts. So in thinking about the presentations from earlier, Dr. Hoagwood, I saw this in your abstract, and I really actually want to start there in thinking about parity. I think we've had a lot of discussion at a national level about mental health parity. We've had acts passed through Congress, but we really have yet to realize it. And I think we know that because our policy and funding agenda still treats mental illness as less than physical health challenges. And so I think that's where we need to start in terms of moving forward. I loved your vision for the future, really thinking about data and technology and how it can help us move forward, shifting from individuals to populations. From my lens, I think we don't have a lot of models that are looking at intergenerational constructs for care. We've talked a little bit about 2 generational approaches, starting in pediatrics, actually. And in my context, I would actually caution for 3 generational approaches because we have a lot of family constructs where grandparents were taking care of children because of impaired caregivers, for example. I've been looking excitedly at the work that Kelly Kelleher has done and looking at Medicaid accountable care organizations as well, because I think those are providing some of those opportunities to leverage funding to address the other social determinants that we constantly are impacted by not being able to address through a solely behavioral health payment stream. I think in terms of the scientific breakthroughs and looking at what was it, exposomes? That was a new word for me today. I was excited to learn about that. Thinking about environmental exposures, which I think is really a good case to make for equity overall, and it doesn't relate to just one socioeconomic demographic at all of our population, and so a really great way to think forward. I loved your ideas around anti-poverty campaigns as well. I think a lot of what I feel like we're tasked with is trying to address poverty and its attendant mental health impacts, and it's very hard to do that just by trying to treat that. In the work that Erin talked about in terms of, again, trying to address the research to practice gap and looking in particular about practice-based research networks. Again, I loved the focus on the clinicians and consumer experiences. As someone who sits in the Department of Behavioral Health and we have all of our ideas, we can develop contracts and payment models around them. If we don't actually address the consumer's experience and the clinicians who have to meet out all of these contractual changes and requirements, then I personally seen the challenges in really trying to get to the outcomes that we would like to. So I really appreciated your take on that. I also liked thinking about other workforce development opportunities. And so from where I sit, focusing on the behavioral health workforce and knowing that most kids will actually never get to that context. And we have some experience trying to roll out a secondary prevention model for PTSD. Great idea, great intervention. However, kids weren't coming to our agencies early enough to actually benefit from that care approach. And so I've been thinking a lot more about opportunities for working with our education partners, and lots of challenges around doing that in terms of prioritizing social emotional health for kids and creating healthier education environments for them, as well as with our child welfare partners and thinking about their role in being sort of on the scene early providers of care, much like we heard about police intervention models, for example, earlier. But again, lots of challenges with addressing that system. Dr. Cahill mentioned learning health networks and the focus really on science, informatics, incentives, and culture. And I think that, especially when thinking about our opportunities and experience with the first episode psychosis model in Philadelphia that's been growing through the state, actually, thinking about that ecology of practice is incredibly important. So I really appreciated your thoughts there. And then I think Dr. Dimet's work really around overall incorporation of physical health care for folks with serious mental illness, and I see this actually with our child population as well, and the high rates of obesity that they experience, that there really are incredible opportunities to move that forward. We have one example in Philadelphia of a reverse co-location clinic, actually, where the primary care provider is being pushed into the mental health center that's really yielding some really important outcomes. But I think, as you point out, attitudes and education for not just the consumers of services, but our providers as well. So Philadelphia declared that we were going smoke-free a few years ago, and our health department is helping in terms of provider education and training for interventions. And we've been, through our policy lens with contracts, moving towards smoke-free hospital units and to come residential rehab units because we knew they were going to be actually ironically harder to get to. But that work has been incredibly important, really informed by that science on the early and premature death of folks with serious mental illness, but much harder than I ever thought it would be to actually move in that direction. So I want to just, I've heard a lot over the last day and a half that I think actually is quite resonant with the talks that we heard this morning as well. And just want to say, in terms of the next big thing, I don't know what it will be, but I really hope that as speakers yesterday and today really called for, that it's really informed by the voices of the people that we're all trying to serve collectively, whether through our policy, research, or practice lens, and that we really work towards helping them achieve a life worth living, as I've heard a lot of our recovery-oriented folks talk about, certainly for kids to be able to realize their full potential. So those are some of my musings. Looks like I have 2 minutes in terms of questions from the audience for our panelists. Or we can go to lunch. Oh, there's a question.
Well, thanks for all of the thoughtful comments. I wanted to just do a little reflection and get your thoughts about something. I mean, once again, if we put your ideas together, then we would need to go beyond we'd have to kind of say, okay, what is health services research about, or mental health services research? And I think the answer would be something like, it's what kind of services or supports do we need for people to either prevent or have successful outcomes, even if they have mental illness. And that might be social services, it might be health service. Like, what is the support for the outcome? Which is kind of where the field of health services research started. It wasn't so much literally about health services research, it was about services for health problems and getting outcomes that we need. I think that could potentially move us beyond practice-based research networks, which are a great thing, to community-based research networks or family-based research networks, or what are the research networks we need to get to the kind of vision that you're all touching on. And Gail, I think with your presentation, I'm thinking, which also builds on some of the last comments, what do we need to get healthcare systems to be attending to severe mental illness? It's not just the community health centers, right? The responsibility. Right, yeah. So, because we have to have the resources for the community health centers to have those programs, and that kind of comes from the overall health agenda. So I'm just wondering, how do we get there? Both what is the research that we need, and how do we as a field need to engage the stakeholders to get there? Anyway, so I just thought I would throw that out to you.
Is there a way to turn this on? Oh, it's on. Just some thoughts. Ken, I agree with you completely that that the focus on the health services is redefining, and I think that we're in a position where we're thinking about systems differently. So I would say it's health services, it's health systems, but not systems in the way we've thought of them before, but rather systems as networks, which includes community networks, it includes health networks, children's hospitals have their own networks, many, many networks, and that also gives us a window into some of the methods around social network analysis, for example, and thinking about complex systems, as John was talking about. Complex adaptive systems have developing methodologies as well. So I think we have to rethink our service systems and take advantage of some of the newer ways of thinking.
I think in terms of the work that I'm doing, I think some of it is just being able to speak up. I think that the mental health program and organization leaders that I've worked with are really interested in moving this forward, but they haven't, they don't know how, and hopefully if I can help kind of target towards like looking at training, looking at outcomes, so their efforts on like wellness programs are more targeted towards things that we know will work, that will help. And then I think the overall health system, I mean, I guess speak for Johns Hopkins, there's so many, we're talking about people that are, patients that are very costly, very high utilizers who are in care management programs through Johns Hopkins that don't know how to deal effectively with these consumers. And so I think it has to be the marriage of some of these things coming together where the people who are taking care of these patients need to be trained to do it and need to realize it. So I guess I feel like for what I do, there is a vision forward, just we need more work.
Yeah, another point I wanted to add that might affect the research agenda would be some of the implications of what you're all talking about is we may need longer-term outcomes, especially, let's say, for child outcomes or dealing with social determinants. A lot of that is not happening in the first 6 months, right? And then some of the implications, Kimberly, of what you were talking about is how do we get more integration in with biomarkers even, which has been a tough sell in the health services field, even though it's such a core thing with NIMH. Maybe it's because we don't have the same genetic markers, so obviously available. But that would be another ask, is how do we integrate some of this with some of the translational science agenda in a meaningful way? Yeah.
So I hate to cut this short, but it is lunchtime, so I want to invite everyone to give our esteemed panel and discussant a round of applause.
Really enjoyed it. Yeah, so nice to meet you.
And if you'd like to continue the discussion, please do come up and do so. Oh, and go see the new investigator posters.